Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
We all have EMS rituals, but are they actually best practice or just muscle memory?
Raise your hand if you've ever hung normal saline just because. Yeah, same.
We're calling ourselves out today, with love.
All right, guys, so this episode is basically, I think we would call them rituals. Things that we do just because we were told that. And recently I was in a training and the medical director asked someone, why did you place the tourniquet there? And they said, that's just the way I was taught. And that is why I put this in here, because that happens often in EMS. Well, that was just the way I was taught. Mm-hmm. Things change a lot in EMS, in medicine, so we do need to adapt. B, we need to know why we're doing something before we do it. That just comes with full understanding of your interventions and your scope. And then also, we don't need to be doing things just because they're in our protocols, or just because, even just because the doctor said to, right? We need to understand fully why we're doing things. And if they are going to be harmful to our patient, it's just a ritual.
All right, first ritual, C-collars and backboards. So, when I very first started EMS, we were still doing standing takedowns.
Dude, that's so weird. What is wrong with us?
It was
looking back.
The first standing takedown I ever did was on the interstate.
Oh my God.
Yeah, guys, see, what? That's so embarrassing.
And I was with the most competent critical care medic that I had ever and really still have ever worked with. She's fantastic. And that was just what you did.
Yeah.
But did it make any sense? Absolutely not.
No. So why do we even immobilize people?
Right. So when you think about your C-collar, what's its purpose?
To limit
movement.
Yeah.
Right. It's really to remind your patient that their neck could be broken, so don't move it.
It's quite literally. It really is.
Yeah, right? It's oh, hey, no thank you. Backboards. What's the purpose of a backboard?
None.
I would like to say, I think to immobilize, but I think it's just to hurt your hips, to be honest.
Right. So ideally, it's for full spinal immobilization, right? And it can even be full body immobilization if you have a multi-system trauma. But what does the actual research show?
That they're
Not
stupid.
much.
Right? That they actually don't really protect your patient's spine at all, and sometimes actually make it worse.
Yeah.
Who would have thought?
100%. And also, whose spine is exactly flat?
0 people.
And you are not. Don't even. First of all, a lot of our patients are larger, so there are no voids to pad. But you are lying to me. You tell me you're padding the voids.
Have you ever actually tried to pad a void?
You can't. You literally
it's
can't.
so hard.
Unless it's like a baby.
Unless you pick them
There's
up.
no voids.
Yeah, it is so difficult. And honestly, anytime that I've ever tried to pad a void, only because the patient has been ow.
Yeah.
It's worse. I'm hurting them trying to pad a void.
Oh, yeah.
Absolutely.
Yeah. No bueno.
I kind of decide if I'm going to call or board somebody. If this was a kid, would I board them?
Oh.
Because
I like
probably
that.
not.
Probably not.
It has to be really crazy.
Because they will not tolerate it. And so EMS historically has over immobilized. Why do we think that is?
Because we were
because
told
it's a ritual.
Yeah. I think it was so, when you thought of EMS, you thought of
a spine board.
Lights, sirens, and spine boards.
Yeah.
Absolutely.
Yeah.
Yeah. And I think that it was a pretty package. And so you get someone out of a car, they go on a spine board, they go in your truck, they cannot move. It is a pretty package. But at the end of the day, especially with elderly patients, it causes significant pressure sores, worsening spinal injuries.
Even with a healthy, like, that is not, like, you're broken, let me lay you on this hard piece of plastic?
Right. Even down to like the back of their head. Like, that is
Yes.
hurty.
Yeah.
What about C-collars? Because right now, everybody is pretty much like taking a step away from long spine boards, right? Everyone's pretty much on board that like these are harmful. Not everybody, but a lot of people.
Yeah.
But what about C-collars? I mean, there are
Well-
some departments that if you are in any,
Even a standing to ground level.
yes,
Like ground
any
level fall.
traumatic event, you get a C-collar. What could be the potential harm of that?
First of all, I just want to say not all C-collars are created equally.
That is
Bet.
true.
And
Yeah.
also, we don't always size them appropriately. There's so
Definitely
many
not.
things that could affect this situation
Mhm.
negatively. So,
Almost every single
choose
person.
wisely.
Yes, almost every single person I have ever met is a no-neck.
Yeah.
And
And some of our other populations, like women or elderly, are pediatric size ones if you're sizing them appropriately.
Yes,
Yeah.
C-collars are built for 6'2" men.
They should literally never be covering their chin if they are, like, and I don't mean like the little lip, but I mean like if your C-collar is not on their neck and it's on their chin, I've seen that so many times, it
It's
is
too
the
big.
wrong size.
It's too big. And I think what is really important is that I've seen people so often that are a little bit altered be in a C-collar, that are agitated,
Mhm.
that are in pain, that are like fighting it.
Yeah.
Do not ever place a C-collar on your patient who is fighting you about it.
And that's why I say if I wouldn't put this on, like if I wouldn't immobilize a child, because they are going to buck the board.
Mhm.
They are. If an adult who's altered, like the same thing, that's a
Mhm.
child at that
Yeah.
point.
If it is going to cause
More harm.
more spinal movement of you
Yes.
trying to fight me on it, then it's not actually serving its purpose.
Yeah. I think a lot of
Yeah.
places are going to just the stretcher, and even with,
Mhm.
I'm seeing more and more go away from C-collars.
Yeah.
Which is good because A, airway risks.
Mm-hmm.
B, if we have really high up injuries, C1, C2, that is not a normal position for that. Like, that is going to cause more harm. Put a C-collar on yourself. Just next shift, put a C-collar on yourself.
And see how that feels.
Tell me how that is going to help your
Yeah.
C1 or C2 fracture.
I would argue, and this is not like clearly nothing in EMS isn't always,
Mhm.
but like I would argue that oftentimes where I find C-collars most useful is with unresponsive patients,
Yes.
only because they cannot control their own head
100%.
movement.
Yeah.
And I think that in that scenario, like that's a great use for it. Some patients are truly having a huge amount of neck pain. They may already have some like numbing or paralysis, C-collar.
Yes.
But a lot of our patients that are like, I'm a little tender,
You're right.
it's going to
you're-
if it's going to upset them more than it's going to help them steer clear.
Yeah, and
Now, what do you do, though, if you transport frequently to a facility that will report you to your state board if you do not use a C-collar?
I am following my local protocols, and if you disagree with that, please take this up with my medical director.
Your documentation will save you,
Per protocol.
yes,
Per
in
protocol.
every scenario where you are doing what is the most appropriate for your patient. If your patient can't tolerate it, document why.
Yes.
Document why it was making their condition worse rather than helping. Document that it was not serving its intended purpose. If you do not document all of these things, then you appear negligent.
Yeah.
But if you document things well, that you are truly doing what is the best for your patient, you're going to be in a much better position to defend yourself.
100%. I had a patient that I immobilized because of truly the mechanism of his injury. He was entrapped in something where he was hanging by his head
Yeah.
with his whole full body weight for more than 20 minutes. And it was he wasn't just hanging from his head, he was like contorted hanging from his head, which he ended up being okay, but where his injuries were, the C-collar was causing more pain. So I just took blocks and we taped this young man to the stretcher essentially, like so he could not
Yes.
move,
Yeah.
because that was
Mhm.
safer and more comfortable. And sometimes you just have to make do, and we did try the C-collar on him and he did not.
It was super
It
painful.
was very painful. So
Mhm.
that I just documented the crap out of it, and I was very nervous based on the facility I was bringing it to that they were going to be mad at me, and they were. But but in my documentation, like
Yeah.
Yeah. Give yourself something to fall back on.
it was the best option for the patient. It was adequate.
Yep.
The patient ended up not having any injuries to their neck.
Yes,
So
and-
it's so rare, guys.
Yes.
Like,
And if your patient truly wants to move their head, a C-collar is not stopping them.
no, I promise they're going to move their head more because they're going to feel like they can't breathe and they're going to get anxious and then they're going to feel like they really can't breathe. And
They
then
do
they're
that
gonna,
like neck.
I was about to
adjusting
say, how many times have
thing.
you seen a patient try to put their hand in the C-collar and do this motion?
Yes.
Absolutely. Yeah, I think that it is super important to remember that like your patient has decisions that they can make.
They can be like, get this the F off me.
And yes, and a lot of times, especially in I would say like these really high acuity facilities, we will go there and they will treat this patient like not like they're a person, like they're just a subject. And I very much want to treat my patients like with humanity.
They
like,
are a person. And
you are a person that has decisions that you can
Yes.
make. If you don't want to lay flat, you don't have to lay flat. If you don't want to see
we
collar,
will try to make it work.
yes, we're going to try to make
And
you
keep you
comfortable.
safe.
Yes, all within reason, clearly. But
Yeah.
like, my goodness, you can't just like attack people.
And don't do things just based on mechanism.
Yeah,
We have all been responsible for that. Sometimes you have to be like, whoa, bro, like this is crazy. Maybe you're just adrenaline is going. You need to sit down. But like, don't do an intervention solely because of the mechanism.
Yeah.
Yeah.
We have like a form that we can fill out. It's like a immobilization criteria form. And I actually like it. I actually like it pretty good. That's what I was about to say. I actually like it. And it has nothing to do with mechanism, which I love. It is just like distracting injuries, impairment from drug or alcohol use, like where the pain is located, and all things like that. And it's like a little criteria that we can do. But yeah, it has nothing to do with mechanism.
Yeah. That's very
Yeah.
ritualistic, I think.
Yes, like
Correct.
stay away from the ritual language of like, well, because it was a
Trauma.
high acuity trauma, because it was a rollover, because it was.
Yes, because someone in the passenger compartment
Yep.
is deceased.
Yes, you want to use your clinical reasoning.
Yes.
All right, ritual number 2, starting IVs just because.
Dun dun dun.
Here's the thing. This
is a ritual that we will not break.
is a ritual, but I have an argument for it.
And that's why I put it in here.
I like
And
that.
I agree. I also start IVs on everybody.
Yeah. Well, I don't start IVs on everybody.
Well, let me just tell you, I had a transfer from and it was for pancreatitis, and they did not start an IV, and I said, you know what, I'm not going to start an IV either. Whatever. They obviously had a reason not to start an IV. And then he proceeded to vomit all over me. And guess what I should have done?
Start an IV.
Then I had to
God
start an
damn
IV
it.
while he's throwing up all over me.
Ugh.
So just start the IV.
Just do it.
Okay.
First and foremost, I just want to say, I think the number one argument that we hear for not starting pre-hospital IVs unless absolutely necessary is infection risk. Okay. This is my soapbox.
That is a very dumb rule, yeah, or
That-
a dumb ideology,
Correct.
in my opinion.
This is my soapbox that I will stand on anytime somebody gives me the opportunity to. Number 1, have you ever watched anybody in an ER start an IV? That is all I'm going to say about
Have
that.
you ever seen a clean ER?
Number 2, while I do understand that we are in situation scenarios, places that are not, let's say, sterile, I do understand that. I do think that EMS as a whole can do about 100 times % better giving EMS supplies to negate that. Number 1, can we please, for the love of God, stop using alcohol preps on literally anything? I hate them. Please give us chloropreps.
Mm-hmm.
Yeah, like
Please let me
the
scrub
little
this
wand
patient.
ones.
Yes, you know what I'm talking about? You
Yeah.
get the little crack. And
Yeah, that's so
shake it out.
satisfying.
Give me a pack of baby wipes.
Yeah, let me clean their skin off first.
Give me
Let me get all the
something.
goo off them, then use a chloroprep, and then like
I wish we had baby wipes, guys. I'm so
Right.
serious.
The really
Pre-
thick ones that the ER
Yes.
has? Yes.
pre-hospital infection rate is not because of pre-hospital providers. It is because of the equipment provided to
and
us.
the comorbidities and the gravity of their
Associated.
illness.
Yes. Theoretically, if I'm starting an IV pre-hospitally, it's because this patient could not get themselves to an ER.
Also, I'm doing it the same way as the ER.
The exact same way. The exact same way. And have you ever watched anyone clean an ER room? It's almost never EVS. It is a quick wipe down with a purple wipe. It is the same as our truck. It is the same.
Yes.
Arguably less clean.
So what we're saying is, this is a ritual we do indoors.
Yes, we do.
Correct.
And I will say
Surprise.
that a lot of people say like, oh, well, the ER is going to start it. And I would say it splits half and half. Half the people are like, that's not a reason. The other half of people are like, yes, it is.
That is not a reason.
Right? I think that the way that my brain works is, one, is this at any point in their course of care clinically indicated?
Yes.
Right? Is the ER going to start an IV? Now, am I going to do it only because the ER is going to do it and there's zero indication now and probably zero indication then? No.
No, because
But is this
they're not
going to
gonna need it.
quicken their course of care? Yes. Is the ER going to start an IV because they're going to draw cultures or they're going to do whatever? Then yes.
also if they need it, you don't want to be stuck without one, because that's when they're like we just talked about, when your patient is actively needing an IV medication and you don't have one, anything could happen en route, right?
You're down bad.
Like, and then
Right.
then what happens in a liability standpoint? Oh, well, why didn't you get an IV?
Mm-hmm.
And my biggest argument for this, when people are like, don't just do it because the ER wants it, strokes.
Yeah, we literally do it. 'Cause
That's
the
my
ER wants
biggest
it.
argument. We start bilateral, large bore,
Yeah,
above
that
the
is
AC
true.
lines.
It's literally in our protocols.
Strictly for the ER. Because what am I giving a stroke? Almost nothing ever.
Yeah.
We are identifying, we are establishing access, we are transporting emergently. Like, that is almost always what we're doing, unless we're to a point where we're managing airway and things like that. But we are only starting IVs with that complaint to
Yeah.
hasten the patient's course of care once they arrive to the ED. And that's important.
That is an intervention.
Yes, because
Expediting care.
when you look at EMS, if you separate EMS from the patient's hospital care, then you're doing it wrong. Because we are the
Yeah.
beginning of their care. We're not a separate form of care. So, like, if you think of the patient's care starting the moment they walk into the doors of the ED, if they're being transported by EMS, it started the moment we walked in their front door. And if you add yourself to that team, then it no longer becomes like, are you starting IVs for nurses? It's what's this patient's course of care, and are they going to need access at some point throughout that care?
I
And
would
can you
say
reasonably
99%,
start it?
Yes. Yes.
Yeah, that's always mine.
And like truly, this, I think I put this in here too, because starting them en route too, like when something changes, can become very difficult, especially if they are declining and you're having to get an IV. If they're stable right now and it is clinically indicated, start the IV. Even if
for it.
you aren't
Mhm.
anticipating at this moment that you might need something.
Mm-hmm.
Yes, if there's a potential that you may need it,
Yeah.
go for it.
Literally, like,
Yeah.
I should have the other day.
Right? Like, be responsible. If this patient is very, very difficult to establish access,
Yes, that is
and
reasonable.
you do not foresee them declining throughout your transport, and you have attempted once or twice, it's okay to then put a stop to those further attempts and wait for somebody that may have an ultrasound machine or, something different.
Oh, yeah. And, like, if that patient is really that bad, as far as their vasculature goes, like, even if something hits the fan, like, you're gonna have to do something a little more aggressive than a IV, probably.
Mhm. Yeah. I think my line is that if you consider yourself a part of this patient's care team, then it becomes actually quite simple to establish whether or not you should get an IV.
Agreed. The last thing that I want to say about this is, please make swabby caps normal in EMS.
Oh
You
my
just
gosh,
put it in the
yes.
IV start kit.
That's what
Why
I'm
is it
saying.
not in the IV start
I think we are the one entity that,
Is behind still, like everything else?
yeah, well, like that needs them the most, you
Yeah.
know? We're the one entity that's going to start an IV and then drag you through mud. Like, can we please get some swabby caps up in here? That's all I'm saying.
Can we please
For
do a
sure.
protectee?
And get better tegaderms
Oh my god.
Yeah.
with the cloth around them.
Please.
That's what we need. If you don't have the cloth infused ones in
Mhm.
EMS,
The lavender infused tegaderms.
those two, okay? But like
We need
everything else,
sage
it's too
infused
sweaty out there,
tegaderms.
man. It's too sweaty out here.
It is.
It really
It is when you have to slap 2 Tegaderms on there and then still co-band it.
Yes, and the only thing truly that's holding it on is Coban.
Yeah.
All right. Let's do
Number
ritual
3.
Number 3.
Oxygen as comfort food.
Yummy,
Just
yummy.
drives me crazy.
Let's hear it.
Sometimes we'll do transfer. It happens a lot in the hospital. I'd say
Mhm.
nowadays more than it does pre-hospital.
Yeah.
I don't think you should be giving the patient comfort oxygen.
Free radical
If-
human.
If everything is fine, their end tidal is fine, their oxygen is fine, something else is causing them to be anxious. So we need to find out what is causing them to be anxious and treat that and fix that. There's something else wrong. So I think it makes us feel better. It probably isn't even going to make them feel better because hypoxia is not causing them to be anxious.
Correcto.
Don't
Do you
give
know
them pretend
what-
oxygen.
Don't give them pretend oxygen. Do you know what anxiety is a sign and symptom of?
Shock.
Literally everything. Literally everything.
Does your tummy hurt? You're
you need to
anxious.
keep
Maybe.
investigating. If they're like getting really like impending doom and their oxygen's fine, you need to do
need
a
to
full assessment again.
PE.
Put on that
Yes.
Sherlock Holmes hat and do
Yes.
some investigating.
Absolutely.
Impending doom with O2 sats that are A-okay.
With the grabby hands.
Mhm.
PE, homie.
PE.
And let me tell you guys, what is oxygen? It's a vasoconstrictor. I just need you
Mhm.
all to understand that.
And
Just
it is a
real-
medication.
Yes, it is a medication.
Yes.
You have to have a clinical indication for it.
Correct.
I don't know why we are still allowed to say patient was placed on oxygen for comfort.
I'm going to be honest, I didn't know that we were.
I
Yeah,
mean,
it's still in a lot of protocol.
yeah.
Oh.
Also, though, like, I think the only time that you're allowed to say a patient was placed on oxygen for comfort is if they're on hospice.
Sure.
Then you can have whatever you want.
Yeah, and also,
Yeah.
like, even patients on ventilators.
Oh, yeah, they love to do 100% FiO2.
Why are we on so much oxygen?
Right, they're like a trauma with no lung disease.
Yes.
And they're completely
There's a
healthy
head
30-year-old male, and they put them on
100%.
100%. Mhm.
I see 80% FiO2 a lot. I'm like,
They can be on 21%.
what are you doing?
Yeah.
Why are you doing
What?
And then you talked about, like, it's a vasoconstrictor.
that? Yes,
So,
STEMIs.
yes.
Why do we do this, guys?
STEMIs and strokes.
Also, we're gonna give, especially in like BLS protocols, you're gonna be like, just give them oxygen, man.
15 liters non-rebreather.
But you can't do anything else to fix anything else. But here's oxygen that could make it worse.
Yeah, you're going to cause vasoconstriction. Like, I understand there's a happy medium.
Yeah.
Like, if their sats are a little bit low, you want to throw them on 2 liters. Like, go for it.
Aubrey, why are you making that face?
I have a question, and this is pause. This is out of the podcast. So if you have a very fun, well, actually, it's not a fun fact. It's a sad fact about oxygen and vasoconstriction in babies.
So, yeah, vasoconstriction impacts your vasculature in a way that is so significant that, fun fact, I was a preemie, and I spent 2 months in the NICU, and my ophthalmologist, I got a new ophthalmologist, and that was the first question she asked me, were you a preemie, and were you on oxygen when you were a baby? Because it affected the vasculature in my eyes so much. And also, I can't see now, okay? So,
You're making people go blind out there.
yeah, okay.
Yeah, take that.
Not actually, but that's how significant the impact is for long-term use of oxygen.
You know what argument I hate
What?
so much? When people are like, yeah, but that doesn't apply for EMS because we're not doing it long enough. for
If
to
they
be
do
a
it if they
problem.
call you every single day.
Right. I also think that we seem to underestimate a lot of times how our care impacts the ER care. And I know we
Yes.
complain a lot that they don't listen to us enough, but I think sometimes they listen to us so much
Yes.
that if we put a patient, say I put a patient on 5
They're
liters,
gonna stay on oxygen until they get discharged.
100%. So if I put a patient on 5 liters O2 nasal cannula, and they're in the ER for 6 hours, and nobody DCs it because they just assume like, okay, whatever,
That's why I titrate oxygen on ventilators coming from other
Right.
facilities.
because they'll leave them on whatever you have them on. And so I think that even though, yes, the 20 minutes I'm with this patient is not going to negatively impact their like free radicals and vasculature and all the things, well, short term potentially,
Yeah.
but it is still responsible to use it responsibly because they may remain on whatever you do for quite some time.
Yes.
Mhm.
And 99% of the time, your oxygen saturation goal is not 100%. So if you're at 100% and you're on oxygen, it's time to titrate that.
You're
Mhm.
doing too much.
You're doing too much.
Mhm. They are
And that is
maxed
the
out.
problem.
They're full.
Yes.
There's no room in the
There
end.
is no room.
No room in the end.
I think a good question for oxygen is ask yourself, does the patient need this? Or am I uncomfortable doing nothing? Like, am I just sitting on my hands being like, well, I guess I could
also,
give you
if
some
you're
oxygen.
uncomfortable with doing nothing, put them on an end-tidal cannula.
Yeah.
We have options these days.
And we
people.
we say we are going to monitor
You're
your
breathing.
breathing with this.
There's not oxygen. I always tell
Sorry,
people,
it smells weird.
here's a
Yeah,
beach
they
ball.
do smell weird.
So, ritual number 4, provider fear rituals. Are you doing something just because you're scared? And this kind of goes back to, did you do something because the patient needed it or because you were scared it would look bad because you didn't do anything?
Mm-hmm.
Or you're scared because you don't actually know what's happening with your patient, so you just start throwing things at them. And that's, again, like what we talked about. Are you doing things because the patient needs them? Or are you doing them because you're doing too much? Are you doing too much because you're scared? I guess that's the question.
Are you doing too much out there? Are you making people go blind? This is what we're asking you.
By the way, this does not happen in adulthood. Just clear that up.
This is for dramatization only. I think that there is a very, well, it's not really that fine of a line. It's a line. There's a line where there are patients that are sick. They're unarguably sick. But maybe they have too many body systems going on that you can maybe fix one of the things that is going on. But in turn, you're going to be more detrimental to their other body systems that is happening. And that is
Yes.
sometimes less is more, is what I'm saying, even
I
in sick
agree.
people.
Yeah.
Yeah, sometimes we can do more harm by doing interventions, even if we
Correct.
feel like it's not going to impact them now.
Correct.
Sometimes people are multi-system metabolic disasters.
Yeah.
And you
Thank you.
One
That was a
thing is
much better
gonna-
way to say
One thing is going to
You
trigger
just said-
a freaking the floodgates to open.
Correct.
Yeah.
You just said everything I was trying to say in one sentence. So congratulations.
But you have sometimes it's a hard
Congrats.
time to figure out like chicken or the egg. Like
Yeah.
which one came first? What can I fix without worsening something else?
Keep it simple, stupid
Mm-hmm.
yes.
is real in
Ab-
some situations.
Absolutely. And
Some-
I think that like for me RSI is a perfect example of this.
Mhm.
Like potentially I have a cardiac issue that has now led to a respiratory failure that I need to manage. But if I manage the respiratory failure via RSI, I can potentially worsen the cardiac
Murder.
issue and we can go into a code. So
Yeah.
like you have to weigh your options. Sometimes I know that we talked about this earlier, but like sometimes ventilating somebody with a BVM for a while you're managing all the other things is the answer.
Yeah,
Mm-hmm.
100%. I think that comes down to like, are you are you capable? If you're capable of doing something and that's why you're doing it, you need to ask yourself, why
Mhm.
am I doing it? Not just because you can.
Right? Guys, you know what we see this a lot in is like respiratory patients where people have not delineated between like the etiology of the respiratory
What's
issue.
the cause?
Yeah.
Yes, like is this obstructive? Is this upper? Is this lower?
We just throw everything.
Or cardiac.
Right? Or yeah, do you have a wheeze
That
but it's
one,
cardiac?
we can almost never determine that.
Right? And so there's lots of things where we will start doing things and like people will go down this like asthma COPD route of meds when it is very clearly not that.
But why do you think that
Yes.
is? I think that ties in beautifully to this. It's
Fear.
a fear. It's the most common, and it's the most amount of meds.
Yeah.
I can throw a lot at them.
Mhm.
I can theoretically do a lot.
Mhm.
Now, is it the right pathway? Absolutely not.
Yes.
But I
And
can
if
look like I'm
we're,
doing
we're
a
not
lot.
saying like if you have a respiratory patient and you throw the whole kitchen sink at them, sometimes they need the whole kitchen
Absolutely.
sink. But
For
if
sure.
it's the right,
Pathology.
yes,
Mhm.
exactly.
We just had a patient last shift that we threw the whole kitchen sink at.
yeah,
Yep.
you
He
got
was-
to. I
yeah.
do it often with
He was
those
a COPD
near
asthma.
failures.
Yes,
Mhm.
he was a COPD asthma exacerbation. He was the most diaphoretic person I've ever seen.
Oh,
He
God.
was tripoding. His respiratory rate was 56
Blech.
on an end tidal. Like his end tidal was 68.
Where's the BiPAP?
Yeah, he wouldn't tolerate it.
Oh, damn.
I know.
That's
but
why we need. Take this out of van.
Mhm.
Yes, but we did Dex, Mag, Epi, continuous nebs, like which we don't have DO nebs, and I wish we did. But like we really
That's
threw
embarrassing.
I know. We really threw the whole kitchen sink at him, and then I like tried to coach him through a BiPAP. I even let him hold it. He just could not tolerate it.
Yeah,
But
he's already too worked up.
he did improve for a little bit. He was on a BiPAP for a couple hours in the ER. He did end up getting intubated later on. But like he was one of those patients where I even asked myself throughout it. Obs and I kind of looked at each other, and I was like, "This is
The right path.
like are
We
throwing
have
all
to do
these
this.
meds appropriately because we don't have time to do one and see if it improves because he'll decline in that time."
That is the. Take this out if you want. That is the stupidest thing ever in protocols, in my opinion. You do this and wait. Do this and wait. No. Sometimes you can't wait. Be a
Mhm.
freaking clinician,
Mhm.
okay?
That's why
It's a
that shit is in
guideline.
there.
Yes, we are already.
We shouldn't have protocols, in my opinion. We should have guidelines.
Yes.
And if you cannot operate within
I love
guidelines,
that.
then guess what? Curb.
Dang.
Ooh,
the
kick it to the curb. No, I love that because it is one of those things where it's like we are so far behind the 8 ball on this already. Like he needs all of it.
Yeah, you have to do that.
All of it.
And I'm sorry if that is not what the legislation says
Yeah.
that
Yeah.
the medical director signed.
Right.
You
But
have to be able to have the clinical judgment to realize how far progressed
Yeah.
you are in this disease
Absolutely.
process.
Yeah, I wish we weren't this progressed. I wish we could sit on it
Yes.
and wait.
Yeah.
Because we've all been to that COPD exacerbation or that asthma exacerbation that has an at-home neb. That's like the
Yeah.
room air, like poopy nebulizers that are just like... And then we do like one neb treatment
Yes,
with an
they're
O2
better.
tank and they're better.
Mhm.
Right? Those are not the patients we're talking about.
Yeah.
We're talking about the
like,
ones where
holy
you're
crap,
like...
how are you still alive?
Yeah. Where we're like, do we need to tube you right now?
Yes.
Yeah.
100%.
Our next ritual. Now, this one I like so much. And we call this cookbook medics.
Yeah,
but
we're basically like talking about this.
treating protocols like spell books. And so Soph just said this. Protocols are guidelines. They are not your 10 commandments.
This is why I feel like you should be, if you're doing CQI or QAing people, you need to be so freaking clinically competent because you need to use your own freaking clinical judgment based on the facts you are given. And sometimes we have to deviate from plan in a reasonable way.
Mhm.
And if you are just QAing people and you're, especially as new medics, I have a really big problem when you're shitting on little baby new medics for using their brains, but they deviated from the protocol in a way that is insignificant. You are, first of all, you're making them scared about doing things that are right for the patient. Secondly, you're giving them false information.
Yeah.
Because what they did was clinically appropriate, but it would be reasonable to say that was clinically appropriate. Just make sure you get a signature next time on medical control, whatever. Also, sometimes we deviate so slightly from the protocol, like we're not going to wait 5 minutes to see if this. If you're QAing someone and you can tell that this patient was literally dying,
Mhm.
and you nick them or knock them because they did not wait the 3 minutes, the 5 minutes that is... what is wrong with you? You're a bad word.
Yes. I would also argue that you're a bit dangerous.
You are
because
dangerous.
if you are sticking to... Now, we're not talking
Sorry,
about...
that was...
I know you guys can't
I-
see this, but Sophie took off her jacket in the middle of that rant, so it
I
was
did.
it was
said, "I
very
got hot."
serious.
But like if you are sticking to the protocols so rigidly that you are ignoring your patient's condition...
That's not good.
It's dangerous
It is
because, again,
dangerous.
protocols cannot equate for every single...
That's
patient
why they shouldn't be
scenario.
called protocols.
And that's why your medical direction... That's why, one, we have medical direction. But two, it's why your medical directors allow clinical judgment. And it's why you are supposed to be a clinician and be able to assess patients, because you have to be able to operate, yes, within protocols, but
You just
within
need to
reason.
put why. If you can
Yes.
verbalize to me why you put why,
Mhm.
like your why is like sound, that is all that matters.
And any good medical director will agree with you.
Yes. And
And
any good FTOs or
Mhm.
someone who's doing the quality assessment of
Yeah.
runs.
Every single QA that I do, because I QA at our department, every single
Yeah.
QA that I do, basically every single advice that I ever give, it boils down to this. Explain it to me better.
Also, not would you have done it.
No,
It's
that's
not
it.
about what you would have
It
done.
is just explain it to me better. Like, if your interventions are not making sense to me, then they're not going to make sense to a court, or they're
Right.
not going to make sense to a physician. So I need you to explain it to me better in your documentation why you made the decisions you made.
And we
these
talk about this a
days-
lot. Like,
yes.
just put why.
Yes, these
Or put the
days
outcome.
of documenting the bare minimum, where it's like picked a patient sick, according to protocol, gave albuterol, ignored patient for remainder of transport, patient fine at ER. Like, the days of that documentation are done.
Yes.
We're no longer just like transport. We're clinicians now,
Yeah.
and we need to behave as such.
We are providers.
Yeah. So if I can't read your run and truly understand the
makes
condition
sense.
of your patient and why your interventions made sense, then that's really every QA I do. It comes down to like, explain it better.
And like your job, I'm not saying like if you're just like freelancing out here. I'm just saying like use clinical discernment. You do it anyway, right? Like
Mhm.
you're doing that on every single call. And we talked about this in our scenes to subpoena talk because nobody puts outcomes of their intervention in their narrative section ever, pretty much. Do that. And if
Yeah.
you do that and you deviate from the protocol, you're kind of covering yourself, right?
Absolutely. Like, patient improved. Patient stated, I can breathe so much better now.
Yes, exactly. That's what I'm saying,
Yeah.
right? And if that is the case, and like every intervention that this provider did not have, okay, there are some things where we just get lucky, but like it was sound thinking, good clinical judgment. The outcome to each intervention was not negative, right? Why? It scares new providers. It
Yeah.
scares them. And
Yeah.
I was talking to the paramedic that I precepted, and this was happening to her, and I was like, if you want me to QA your stuff, I will. But, like, I think it comes down to also, in this scenario, I know I'm, like, getting way off into the weeds, but, like, be careful who you take advice from. Just because they're QAing you doesn't mean they're right. If you feel like you did everything right and you need reassurance that you did everything right, take it to someone else and have them look at it.
Sure.
Take it to somebody at your station, or take it to your take it to somebody where you can have, like, a real talk with.
Ask questions, have
Yes.
conversations. If you get a comment on a run or a QA or whatever it is, and you wholeheartedly disagree with their assessment of your interventions, have a conversation with them.
Yeah, and if they're not willing to have a conversation with you,
Take it to your educator.
but they should also be able to explain their clinical judgment. They shouldn't be able to say, well, you didn't follow protocol.
Yes.
They also need to explain why their clinical judgment differs from yours, and it shouldn't just be because the protocol said so.
Yeah, and some of our things that we have, like, in protocol, or, like, when we do QAs, I have to be like, hey, you missed this, this, and this on this check sheet. That is in our protocol. Almost every time, my, like, advice is, like, it is your clinical judgment to do or not to do. Just document why or why not.
That's what it always comes down
Yes,
to.
it is
guys.
not like, hey, you didn't do this one thing, so you're going to get docked for it. The point is, tell me why you didn't do it.
Yes.
Like, this was a chest pain
We should
call.
be encouraging autonomy.
Yes, like, this is chest pain. You didn't give aspirin nitro.
You always have to give aspirin.
Right? No, true.
Yeah,
Like, I totally
exactly.
trust your clinical judgment. Tell me why you didn't give it. Did the patient refuse? Was it not indicated? Was it not symptomatic? Like, tell me why.
Yes, because there are plenty of people who don't give it because they're just like, they're anxious. It's not cardiac. I'm like, can you prove that?
Can you prove that? But then sometimes the patient's like, absolutely not. I do not want that. It gives me a headache. And nobody writes that down.
Nobody writes it down.
I think we talk a lot about just how different EMS is from any other medicine. And it's true. It is very different. And it's different not because there's just a circus happening outside every day, but it's different because medicine changes based on where you found this person, right? Sometimes in your protocol, you're going to do A, B, C, and D, right? You're supposed to. Sometimes you can't because you are...
You cannot. Yeah.
You are, I don't know, getting this cow away from a patient. Like,
Or
it's
getting
crazy
beat
out
up.
there.
I don't even know.
Exactly. It is the one facet of medicine where you're
cow away from
like, you just have no idea what's
You
happening out there.
don't.
Yeah, sometimes your patient encounter to EKG 10-minute time limit is impossible because they're in a tree.
Or they're like, sorry, I have to get all these belongings around my house.
Yeah, sometimes it is something a little.
Yeah, someone's like, why was
Underwhelming.
your scene time 45 minutes until you
would not
called
get on
this
the
code
stretcher.
STEMI? And I'm like, because this mama kept just wandering around trying to find her purse.
And what am I supposed to do? Scoop up Mama and
She-
leave her purse behind? Absolutely
Absolutely
not.
not.
I'm
She's
not
No,
doing
so
she'd
that.
be so mad at me.
You gotta get her pocketbook.
But anyway, all of that to say, for the people who like to armchair quarterback, just always remember, if you were not on that scene, you truly do not know that situation, because there are about 1,000,005 variables that could have changed whatever clinical outcome that you think you would have had. You have no idea.
And I would challenge you that if you are the provider on said scene, that it is your personal responsibility to document it so well that anyone reading your run report is
Would
in your
understand.
shoes on that scene.
Correct.
For sure.
Correct.
Mhm. Yeah, and it just comes down to, like, does this patient need this, or does this paper just tell me to do it?
Yeah, and that's... Use your brain.
Use your brain.
Just use your brain.
That's all it comes down to.
Use your brain. Be responsible. Do not go rogue and start freelancing outside
Don't
protocol.
be scary.
Don't be
No.
like a ridiculous human being. Please understand that we are talking to reasonable clinicians.
Yeah, this is in the scenario of, like, you know what you're doing.
Yes. Like, if you are relatively lost and confused, a little
Call
bit
for
dazed and confused, as you
help.
will, follow your protocols as strictly as you possibly can.
Or
If-
call for help.
Or call for help.
If you like to use your brain, please think about what your patient needs.
And ask yourself why every time you do something.
And at the end of the day, pics or it didn't happen. Not HIPAA violating pics. I mean your documentation.
Oh yeah, you better, because you cannot do that.
You cannot do that.
You know, our
Unless
little
it's in the chart.
outline that Soph made us, it says how to teach partners to think independently, and I really like that
Yeah.
point. And it's tough because you kind of become each other.
Mm-hmm.
I didn't realize how much you become each other
You
until
trust very blindly.
yeah.
Mm-hmm.
And a lot of times it is a trust but verify situation, and I did not realize how much Obs and I had kind of become each other until she got her medic, and then she started doing things different ways.
Mm-hmm.
And I was like, what are you doing?
That's not how we do that.
That's not how we do it. And you said, no, that's not how you do it. And I was like, ugh. But it's become so valuable because now you think a little bit differently than I think.
It's helpful.
It's so helpful because she'll be like, hey, James, I'm actually kind of going down this path. And it might be something that my brain did not even clock or something that I missed. And it's a really cool moment. So try not to just be like carbon copies of each other. Try to like have different clinical judgment and understanding. And like, it is a really cool moment when your partner gives you a what about this scenario. And you're like, let's do that instead.
Yeah. And that's the thing, too, is like you are two different brains. You are seeing two different things. So if your partner has a different perspective than you, that's a good thing because you guys are keeping your eyes on different things.
Yeah.
All at the same time.
Make it a two brains are better than one scenario. Don't just mesh them together and make them one brain.
Yeah. And just be like, oh, well, they think that we should do this, so I guess I was wrong.
Right. And as easy as it is to autopilot when you're double medic on your partner's call, don't.
Yeah, don't.
Be a partner for them. Pay attention. Like, give them your clinical expertise.
That is respectful to your partner because
Yes.
you would never want them to miss something that you could prevent and potentially lose their livelihood for.
Absolutely. You don't want to end up when they look at you and they're like, what do you think? And you're like, I don't even know what's happening right now.
How do we get here?
How do I know that's not fun? Because I've done it.
Yeah, exactly.
Same.
And we all have because we get on autopilot.
Yeah.
Just about breaking the rituals.
Absolutely.
Speaking of breaking rituals, that's our next section. Breaking rituals with intention. So, we're going to go around and we're going to ask a series of questions to ourselves. The first question is one EMS ritual you personally let go of.
I can talk for James. No, I'm just kidding.
No, please do.
I was going to say, removing aspirin and nitro from the bench seat.
That's exactly what I was going to say.
I don't
Oh my
know
God.
why we had
Why?
tactical
Yeah.
aspirin
That's
and
on every
tactical
truck.
nitro.
I don't know if that's a regional thing or if it's universal.
That is
but
exactly what I was going to say.
Oh, okay.
Is that I have always felt like we give aspirin and nitro out a little bit too liberally for patients that are complaining of chest pain and it is likely not a cardiac etiology, or even if it is, they are non-symptomatic.
Yes.
And so it is something that I did not quite realize, that there was a delineation between someone saying I have chest pain and someone having symptomatic chest pain, and the treatment of such, it hinges on symptomatic chest pain. And so I was like, man, I really hate giving this, but I mean, like, I have to because I don't have a reason not to. And then Obs was like, this is a good way to use your protocols to have appropriate clinical judgment, like use them together as your advantage.
You're a
Because
whole person with a whole brain.
Yeah, it specifies symptomatic chest pain. And so that gives you the, I think, authority to be like, this is not necessary
We need
in
to
this
deviate
moment. From the norm.
Yeah.
Absolutely. And so, yeah, I am now I use my clinical judgment much more with chest pain calls based on aspirin and nitro. And if it's truly in the patient's best interest in the current condition that they're in. And you taught me that. That's something that I've let go of.
Aww.
You took away my aspirin and nitro off the bench seat, and it took me a year to get used to it.
I mean, it really it's too accessible.
It is. I don't know.
Medication
don't
should be
need
with the
tactical
medications.
medication.
Yeah.
Yes.
Obs looked at me one time and she said, have you ever given tactical nitro? And I was like, no. She said, okay, good. It's going away. It's going in the med
It's true.
cabinet.
Like, you don't need it emergently.
No.
Emergent nitro. I think for me, it's doing things because the hospital expects me to do them. Because I'm scared that they're going to report me to the state. There are lots of things that they expect that are wrong.
Mm-hmm.
Just because you're a doctor or your facility or your organization doesn't mean you're God. It just like you don't get to say what's appropriate in literally every tiny little situation ever.
Yes, because you do not.
You weren't there.
Yes, you were not there. Absolutely.
And that I used to be so scared, like so scared.
Yeah.
Next question: what changed after you trusted real clinical judgment instead? I would say that my patients got more comfortable. Right?
I think I got more confident.
Yeah. Because you can stand on business. Be like, I did this because it was appropriate.
It's
not because you wanted me
clocking
to.
you.
Yeah. Absolutely.
I'm just going to echo that. A confidence, for
Yeah.
sure. I've only been a medic for 2 years, so I'm still in that, like, I don't have...
To be perfectly honest, Aubrey never really did protocol medicine. She almost always only did clinical judgment medicine.
Yeah, but I think at the beginning, and still now, I struggle with this a little bit. I lack the confidence to really stand 10 toes down on that. You know what I mean? Like, I would do it, but then I would be in the boat you're talking about when
Like,
I get at the facility and be like, I didn't do this because I thought
sorry.
Exactly.
Yeah.
But I think now as time goes on and, you know, you get to see the results of doing the clinically right thing for your patient, every time that happens, you get a little bit more confident, and you were able to walk in that ER and be like, I did this, I did this, I did this, I did this. Have a great day.
And they're like,
Yeah.
did you do this? And you're like,
No, I did not.
Yes, I got super lucky really early on in my career that I was able to be partnered with people that they used clinical
I was
judgment
just about to say that.
Yep.
far over protocols. And so I have always been confident in that scenario.
Oh, and be
then,
that for someone else.
Yeah. And then as I
Absolutely,
got on
she
my
has been.
own, as I got on my own, the more it's like the more you exercise it, the better you are at it. So the
Yeah.
more I used clinical judgment in tandem with protocol and figured out what was appropriate, what wasn't, what applied, what didn't, I got much more confident in it. And now it is almost like second nature.
Yeah. You just
Like,
do what's right.
Yes, I know what is within protocol. I know what is within guideline, and I will make sure that I'm doing the most appropriate thing for my patient, and I'm not afraid to justify that.
Yeah.
And I think that when you get there, it is a really cool feeling because you're like, no, I know what I'm doing.
And I think it's a lot easier to justify, too, in the moment. Like, I did this because it was clinically indicated or not clinically indicated is why I skipped that step rather than being like, well, the protocol said so.
Mm-hmm. I also think
100%.
that you are far more open when this is your outlook, and I can only really speak for myself, but I am far more open to being like, I messed up. I'm much more open to being like, I made a poor clinical decision, or this was the decision making.
that.
Yeah, or this was the process I was going down. Now that we're at the ER and we have more clinical information,
Hindsight is
now I know that
20/20.
that was not necessarily the case. I
Mhm.
did the best with what I could, but clearly we're here. I am much more open to understanding mistakes and shortcomings and even failures because I'm constantly trying to use my brain. And I think that that helps too when you have a partner that's doing the same thing, because you can be like, ugh, like
Yeah.
we got rabbit holed or we went down the wrong path,
And
or
that happens.
we
Like,
just didn't have
Yeah.
enough information really.
there are so many factors that are distracting in EMS, not just that there's maybe distracting injury or distracting family member, but like you have to download so much information in such a short, chaotic period of time
Mhm.
that like there is no way you're going to get every single thing that you need to know every single
Yeah.
time.
Yeah.
And we don't talk about it enough, but almost
A
every
million
single
variables.
case is trust but verify.
Mhm.
You are just constantly in a situation of trust but verify with
Yes,
anything
yeah.
anyone tells you, and
Absolutely.
all of your clinical judgment hinges on all of that information.
And it's no disrespect to co-responders or anything like that, or family, or or sending facilities, but like that's the same thing with each other. Like you were talking about, like we need to trust but verify each other also.
Mhm.
Like we're protecting ourselves and our patient when we
Yeah.
do that, for sure.
For sure. It is similar to like, you know how we get frustrated with the ER because the nurses will be like, okay, like, are you sure?
Yeah.
And then they'll do it themselves. And I used to be like,
Like
ugh,
they
that's so
don't-
disrespectful. But I now have experienced that so many times where a co-responder will tell me something and it is so far from on point with what we're doing that I'm like, oh my gosh. And that's happened
We
so
have
many
to.
times that now I'm like, thank you. I will now verify that for myself. And so now when staff does that, I see it more as being a responsible provider than like being
Absolutely.
disrespectful.
And I think that is, don't take it personally.
Yeah,
I think
if you
that's
just
really good
take the
advice.
phrase trust but verify and you apply it to everybody that you work with, you will stop being offended by so many things.
Yeah.
Yeah.
Our medical director the day, we were doing a scenario and they said, well, I just trusted what they said. And he was like, don't trust anybody. It's not disrespectful. Do not trust anybody.
Mhm.
And he was like, there's no way you can be certain that their equipment is up to par, that it's operating appropriately, that they are trained
Mhm.
appropriately, that they are held to the same standard as you. Do not trust anyone.
And
Yeah.
humans are humans.
Don't
We
be
make
an asshole.
mistakes. Yeah.
Like,
Yeah, like have you ever tried to get a blood pressure and someone says, what was that? And you start with,
yeah,
okay, well,
that means you don't know.
yeah.
That's
If I
okay.
do that, don't believe me. And if you do it, I'm not going to believe you.
Or it means it's really bad, and I'm like,
I regret to inform you.
Do you want me to tell you?
The only number I could hear was 50, and that is it. It's not good. I don't know if it's top or bottom, but it's
Yeah.
not good either way.
Like,
Oh,
all right. The
goodness.
next question is, what advice would you give a new EMT or medic stuck in the we've always done this way mindset, or maybe they are coming in to work with someone who's stuck in that mindset. For me, I would just tell them, like, you're going to teach people who have been doing this a long time things. Because medicine changes, and you're learning, hopefully, when you're going through school, the most up-to-date version of things. So you're going to have insight that your partner might not have, and you're going to have insight in general, no matter how long you've been doing this, that your partner doesn't have, because you've lived a completely separate life than them. So if you are certain that things are a certain way, and you have a partner that's like, well, I've always done it this way, you kids, just coming out with your fancy stuff. We hear that a lot with end-tidal.
Oh, so much with end-tidal.
I'm not going to stop using end-tidal because some grumpy medic just didn't have it. Just because you didn't have it doesn't mean we don't need it.
And sometimes people will be like, well, I mean, I can already figure that out. And I'm like, great. I'm so glad that your clinical judgment is so good that you've already figured out what's wrong with this patient. Now, do every single thing you can to support that decision you just made. Like, yes, you know they're septic without end-tidal. Perfect. Why not have one more number that supports what you are claiming to be true?
I think
like, it is so
how
useful.
bad is this, too? Like, that is, like, it's the nail in the coffin for a lot of things.
For sure.
I recently made a post about end-tidal. I know this is a little bit off. But somebody commented and said, why do I need it if I'm not going to make clinical decisions based on it? And I was like, what?
But why aren't you?
But that's the thing, is like, people don't know what they don't know, even if they're choosing to stay ignorant. But even as a new provider, or you've just leveled up as a medic, take that. It's a responsibility, right? You have new knowledge that someone else might not have. And if they treat you poorly because you have knowledge that they don't have yet, that is on them. Don't take it personally, but do your best to try to you know, teach everyone that you come into contact with.
For sure.
I think everybody that is using end-tidal, we really got off in the weeds on
But
end-tidal,
this
but
is-
my God,
We wanna teach you guys
love
about
talking about
end-tidal.
it. I think anybody that is using end-tidal for clinical judgment and, you know, another number that can be the nail in the coffin for whatever pathology you're going down, that is wonderful. Keep doing it. To everybody else that is against end-tidal, look at it. If you're going to look at it as anything, look at it as this. It is a documentation tool. At its very least, it is a documentation tool. Use it as bad.
That you can prove that your intubation was successful and was in the trachea with end-tidal is the same way that you can support a lot of clinical decisions you make with end-tidal.
At the very least, you can definitively look back and say, my patient was breathing this entire transport. Like,
even like, it's easier. It documents your respiratory rate for you.
Yep.
Like, it's fantastic. I will say that if you use end-tidal frequently, you need to go back. You need to check your respiratory rate, make sure it's appropriate. You need to check your end-tidal, make sure it's reading correctly, because if people breathe out of their mouth, it doesn't. If not, please document that you have erroneous vital signs.
Yeah, that's
because
very
if not,
important.
it appears as though your patient's breathing 3 times a minute. Just a side note.
Yes.
that's bad.
I will say with providers that, I'm not even going to say older providers, because there are young providers that are like this, but with providers that are stuck in their ways of like, well, I've always done it this way. The way that you bring up information to them is what is going to make or break whether or not they're open to listening to you. And if your goal is to educate, then instead of saying you're a little poo-poo head and you need to listen to what I'm saying, on a call, say, hey, can we try this? Hey, can we try putting them on end-tidal? If you phrase it like that, hey, can we try throwing end-tidal on them? Nobody's going to say, no, you can't try it.
Yeah, that would be weird.
It's weird. It's a weird
it's
thing.
a weird response.
Yeah, you phrase it in a way that it's weird to say no to, and then they're like, sure. Maybe later they might be like, why did you want to try that?
Yeah, or like, you don't have to do that next time. Yeah.
And then you can explain why you wanted to try it.
Why it was helpful.
Yeah, it's kind of like, you know, when little kids, when you have something yummy, like a yummy snack, and little kids will be like, can I try it? And I'm like, you've had Cheez-Its 112 times.
Yeah.
You don't need to try it.
Yeah.
But it's harder to say no to them when they phrase it that way.
Yeah.
It's the same thing. With a newer intervention that somebody thinks is maybe unnecessary, or they aren't quite tracking why you want to do it, if you phrase it that way, it's harder for them to say no. And they may ask questions.
And, like, there was a time, I'm going to be so honest with you guys, there was a time where you were going to have to, like, tear bicarb out of my cold, dead hands.
I do remember that time. Yeah.
Okay. And it wasn't for the sake of, like, it really wasn't like, oh, I just want to give it on every code. It was like, if I'm going to call this on scene, I wanted to give it, but that still didn't really matter, because what was I reversing? You know what I mean? And I started reading, and then I was like,
potentially
okay,
was just
I'm so
making
sorry.
I potentially was just making their acidosis worse because then the bicarb would break down and turn right back into acid.
Yeah, I was just doing a ritual, and I was upset that someone was taking my ritual away.
Yeah.
And I was being stupid. Okay? But now, take my bicarb. I don't... And by the way, the company that we work for, they moved our bicarb into the vials, so you have to draw it up. And it makes it harder. So I honestly think that I don't think they did that on purpose.
It was just a happy accident. I fear.
Yes,
however, it worked out nicely.
Because now, like, if you really
it's not in a Brista jet.
Yeah, if you really need it,
you got to work for it.
You got to work for it.
Literally.
And boy, you gotta find your 60 ml syringe wherever it is.
And it's still really hard.
It is. It is, but it works because then when you really need it, you go for it.
Yeah. 100%. Here's what the research actually says.
So here's what the research actually says. So NAMS and ASCOT.
Don't giggle at Ascot.
Yeah, that's a little rude, but it's funny.
Okay.
They get enough flack for their name.
Joint position paper on spinal motion restriction in 2018.
2018, guys.
2018. So it's been a hot minute. Calls for abandoning routine backboards.
Dang.
They literally are like, get out of here.
Get out of here. So the Journal of Trauma in 2010 found that there's increased mortality in backboarding trauma patients.
Dang.
Right, so it's not only that it's not helping, it's actually making things significantly
It's probably making them
worse.
acidotic, guys. You're strapping them to a piece of plastic.
Not good. Yeah, lots of breakdown.
That's in 2010.
Lerner et al. Pre-hospital emergency care in 2019 supports selective spinal clearance over universal immobilization.
Thank God.
Which is just logical. And then PHTLS, the 9th edition, endorses spinal motion restriction, not rigid immobilization.
So you're caught.
You're caught. Right, don't let them run to the hospital.
Preferably not. I do not want to chase after them, so. But yeah, like all these studies are like older studies, guys, and PHTLS.
Yeah.
I can't tell you how many times people have been like, well, PHTLS. I'm like, read the fine print. It's kind of like people who are like, well, AJ says canceled. Okay, read the fine print.
Read the fine
I don't
print.
agree with them, but also read the fine print. Get your research booties out.
Yes, and a lot of times, organizations that make guidelines never use the word always. They use the word often, sometimes, recommended, guideline.
Except for, Ascot, they said we
Absolutely
are
not.
abandoning it. They call for abandoning routine backboards.
They said, please stop strapping people to planks of wood. Turns out it's weird.
And honestly, that's the thing, is it literally used to be wood, guys. How weird is that?
Do you remember in EMT school when we learned hip board splints, which was attaching somebody to a 2x4?
Yes.
Yeah.
We didn't even carry them when I learned them. We still learned them.
Either.
You know how mad I was when I got out of school and I realized that wasn't even a thing?
That nobody was going to try to drag me around by the board attached to my
I was
leg.
so mad.
You know what I would beg to say is better option would be like a KED.
Yeah.
Why did we abandon those? Because the nice ones, the soft ones, they're still more rigid, but like,
I think
you
the only
need to move
reason
somebody.
the only
too many
reason we
buckles.
ever abandon a KED is because it is too long
It's too long.
to
Like
put
it
on. It
takes
takes us
too
too
long.
long.
Oh, I was like, it's a short guy.
It's
What you
long.
mean?
No, is that it takes you longer than 1 minute to put it on somebody, and we decided we didn't like it.
Well,
But it's so
maybe
cool.
we should
You can
revisit.
lift people out of cars with them.
I've used them as pelvic binders.
I use them to. Austin and I use them to extricate somebody out of the bottom of a stairwell.
And also, Austin and I used it to extricate somebody who was upside down in their car.
That is honestly his go-to when he
Yeah.
doesn't know how to get somebody out of something. He's like,
Just-
put a KD on him.
Yeah, because it's got a lot of straps for you to
Yeah.
grab.
It works so well. It has little handles and everything.
Yeah, it worked very well. I also think that KD is nice if you do have like open femur fractures where you can't put a traction splint on. In most cases, you can use it as both, right? You can use it as a pelvic binder because a lot of places still don't have pelvic binders. They just have sheets. They're like make do. And you can immobilize your femurs at the same time.
To be clear, when Soap is talking about using a KD as a pelvic binder or femur immobilization, you are not putting it on their back.
Yeah, you're flipping it over,
Yeah.
like upside down. So.
Just so we're all
And
direct.
I'm not like necessarily endorsing it, but like sometimes you just got to do what you got to do.
Oh, like the same thing that we would like use a sheet, or we would use sometimes
Right.
your equipment malfunctions. Sometimes somebody takes all the Velcro off of your traction splint and you don't know how to put it back on.
Not speaking from
Where is
experience
the
or
ankle
anything.
strap?
That's never happened to me before. But yeah, sometimes things just happen. Sometimes you get a call at 6:55 and you jump it before the other crew gets off and you don't have a chance to check off your truck, and turns out you're missing stuff. Like,
Yeah.
sometimes you end up in a situation where you have to improvise.
And also, the regular size, for example, Sam tracked insulins, they don't even fit me, guys. So, like, you think that's going to fit a granny? No.
Yeah, you cannot pull traction on Soph with a regular size traction splint.
And that's ridiculous, because I'm not, like...
You're like a normal sized woman.
Yeah. I'm just like, I would say I'm an average sized granny. That's what I always say to people. I am an average sized grandma.
Yeah.
Yeah.
I am an average sized grandma. I know that I am, and that's what I always use when we're, like, trying to, like, change equipment and stuff. I'm like, well, I'm an average sized grandma, okay?
Yeah.
So if it doesn't fit me, then it's not going to fit an average sized grandma, and that is a problem.
Yeah, it's not going to fit 70%
That's our
of our
clientele.
patient population. Yeah.
Our clientele.
Well, that was fun. All right, guys, let's leave you with a few points here. Leadership is teaching your team why you do something, not just handing down old rituals. Breaking routines is how you grow the next generation.
For me, it took one call to learn that comfort doesn't equal care. Breaking a ritual doesn't make you less of a provider. It makes you a smarter one.
Rituals feel safe. Evidence saves patients. The research is clear. Judgment beats habit every single time.
Yes.
Yeah, boy.
I can't snap. That was my best effort. All right. See you later.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.